Thank you. I'm the project manager for the National Safer Supply Community Practice. What I'd like to do is start off with going through some, oops, sorry, why can't I change my slide? There we go. I'd like to just start off with some housekeeping things as people are joining us. We will reiterate these in the chat. And then I'd like to do an acknowledgement of our colonial past and history and present. And then do a little introduction to this about the community practice in this talk, and then pass it over to our speaker today, Nanky Rai. So we are recording this event, and we will be sharing it on our website and also in our Google Drive. If you are having technical difficulties, please log out and rejoin. It's really difficult for us to provide any technical support during the actual webinar. I'm really happy to say that we do have French language interpretation. We are, the way we are doing that, I'm going to let Gabrielle explain. Gabrielle Villeneuve is here to do the interpretation. There's some conflict between providing closed captioning. So we've come up with a solution for today. We're trying to find a better ongoing solution, but our temporary fix for today is to have the French translation happening on a Google Doc. The link to that Google Doc is in the chat. Gabrielle, would you like to explain that in French, please?
Absolutely, yeah.
Introduce yourself.
Thank you, Rebecca. Donc, je m'appelle Gabrielle Villeneuve. J'offre la traduction simultanée en français aujourd'hui. Puis, étant donné que le sous-titrage en anglais a été demandé pour la présentation, c'est impossible sur Zoom, malheureusement, d'avoir les sous-titrages en français et en anglais. Donc, ce qu'on a fait, c'est qu'on a créé un document Google Doc où est-ce que je vais transcrire la présentation, écrire les sous-titres en direct. Vous pouvez suivre le Google Doc. Je vais ajouter un lien dans le chat. Donc, juste à cliquer sur ce lien-là, vous devriez y avoir accès. Puis, vous allez pouvoir suivre en direct ma traduction. Bonne présentation. Thank you, Rebecca.
Thank you. Thank you. So the closed captioning is available in the English. You should be seeing that now. Yeah. Okay, so we are joined. We have, how many participants do we have now, Robin? 137 people here from across Canada, and I'm actually located in Mexico right now. And so I do want to acknowledge that we are all people who are living on Solon Indigenous lands, and we're here in different capacities as colonizers, settlers, as new people from across the world. And we're coming here today from different places across Turtle Island. And we're people who live on treaty lands and unceded territories. We work in a sector whose goal is to address social harms, and we must recognize that the production of these harms it comes from the history of colonialism and its enduring practices, institutions, and ways of thinking, as well as other additional systems of oppression and violence. Colonialism is with us today. And part of the work that we're doing and the work that we must continue to do is to work in ways that reshape these institutions and practices that have caused harm. We need to be focusing on repairing harms and preventing future harms, and work towards a more inclusive and just future. So a little bit about the community of practice. We started informally just over a year ago as a group in Ontario, but this year we received funding from Health Canada and from the Substance Use and Addictions Program. Our goal is to support the scale up of safer supply programs through capacity building and knowledge exchange. excuse my cat. The focus of our community of practice is a medical model of safer supply. And what does that mean? That means that we're looking at a model that is prescribed through our medical health providers through prescriptions. But we do focus on a medical model that is delivered from a harm reduction and public health approach. And we also support ongoing advocacy for non-medical models and decriminalization. What we offer is we offer lots of different resources and activities and events. We're going to be launching a prescriber consult line within the near future, workshops, consultations and support, knowledge exchange events like this, working groups, and a network of supportive interdisciplinary providers and people who use drugs and stakeholders in the community. So we're starting today. This is our launch of our community of practice, really. We're here to introduce you to the community of practice and our team of knowledge providers, administrators, and myself. And so why have we chosen to do a talk that's not about safer supply specifically? Why are we talking about medical violence and anti-oppression? And we chose to ask Nanky to do this presentation for us today on medical violence and building an anti-oppressive practice, because we wanted to start off with really presenting what our values and approach to this work is, to really situate it in a particular way. We really wanted to highlight what our guiding principles and values are, what kind of approach to a medical model we are supporting and promoting. And that is an approach that's based in harm reduction, equity, inclusion, social justice, dignity, and hope. We also felt that this really demonstrates the possibilities of safer supply programs and prescribing. Safer supply comes from people who use drugs. It was a call made by people who use drugs. And this medical model, we know that people who use drugs have experienced barriers to care and a lot of stigmatization, discrimination, and violence within our healthcare and social care settings. And so there's this possibility, and Nanky's presentation is challenging us to take up this possibility of transforming the delivery of healthcare and social service care. It's also an opportunity to reconfigure the relationships between people who use drugs as patients, clients, and health and social care providers. So looking at trying to repair those harms and establish some respectful, trusting, collaborative relationships. And ultimately, I just want to drugs to working with people, is that's on a continuum of care. And we also need additional options, more entry points into care, and we also need non-medical models of safer supply. So with that, I'd like to turn it over to Nanky to introduce yourself, please, Nanky. And thank you so much for being here. It's such an honor to have you as our inaugural speaker. Thank you.
Thanks so much, Rebecca, for inviting me for this conversation and for kind of laying out a preemptive to what the conversation will be about. I'm assuming we have folks here from all across so-called Canada, and the other assumption I'm making is that people who are here right now are likely folks who are either interested in or already working in safer supply programs. So just wanted to flag that that's who I'm assuming the audience is. I'm just going to share screen here. There we go. Make sure it's all covered here. Okay. Are you able to see that okay? Perfect. Okay, so wanted to just start by introducing myself. Thanks, Rebecca, for the the introduction as well. I'm a family physician. I work out of the Parkdale Queen West Community Health Center Safer Opioid Supply Program, which is short for SOS here. You can reach out to me on Twitter at that handle. You can also connect with me afterwards by email. I'm happy to share that in the chat later. And what I'm hoping that we can talk about today is recognize the importance of safer supply in the current context, while collectively being able to critique and demand better of all of us in terms of how we provide safer supply. And some of the common traps that I find myself in when I'm prescribing this hybrid medicalized model of something that really should be rooted in an issue of justice and policy. So hopefully that will make sense soon. Just wanted to start by situating myself. I appreciate for Rebecca and the organizers for doing a land acknowledgement. I think important for me to just kind of acknowledge where I sit within the current relationship to the land that I'm on. So I'm a migrant settler. I come from an area in the world called Kashmir, which is in between India, China, and Pakistan. And my family particularly comes from the area that's currently militarily occupied by India. And so the reason why I share that is just because conversations around land confiscation and resource extraction and militarization have been something that I had heard from childhood until present day. But it was important for me as someone who moved to Canada at the age of 10 to realize how I now had shifted in the spectrum of that equation of who had power and who didn't as a settler here on these territories. And so, you know, I think a lot of people say like the land, it doesn't itself need to be acknowledged. The land knows who it is. The stewards and the Indigenous nations who have been, who have had stewardship and jurisdiction over these territories know who they are. So my point for doing the land acknowledgement is not just to recognize ongoing Indigenous presence and fight against the erasure that Indigenous nations experience. But part of my rationale for doing the land acknowledgement is to recognize that I can't struggle for the self-determination and sovereignty of all Kashmiris without actively supporting Indigenous sovereignty movements here. And that includes all movements for land back across so-called Canada as well. And I encourage you, if you're not familiar with the territories that you're on, and if they are unceded or if there are treaties signed to them, I encourage you to look online and to learn more about that. And beyond the acknowledgement piece, to really work towards figuring out what your relationship is to the land that's continuing to support, care for, house all of us in the current moment. So I'm going to try this. I'm going to see if it works. I'm hoping everyone has access to the bar at the top of their Zoom where you can click on annotate. Maybe Rebecca, you can let me know if people have access to that or not.
Truth is, I'm not sure. I'm just looking for it now.
Here. And some folks can try. So the goal is if you click on annotate at the top there, you should be able to get access to something called draw or text, but draw or stamp work well, where you can get like a check mark or an X or a heart, or a star, whatever you'd like, question mark. And I'm hoping
I don't think
that
annotate is available during webinars. I think just during meetings.
Ah, okay. All right, then. We will pivot then and try something else. So I guess what I will leave you with is for your own self, kind of see where you would fall. It's always interesting for me to kind of see where people put themselves around the spectrum. So this first question is, safer supply programs are an exception to oppressive healthcare practices. And if some folks feel comfortable sharing in the chat, if they agree with that or don't agree, you know, either strongly disagree or strongly agree, feel free to do that. Or for your own mental mark, kind of see where you feel on that spectrum. Do you really feel like, do you strongly agree that safer supply programs are an exception to oppressive healthcare practice or not? And I'll keep an eye on the chat if people do submit anything. Oh yeah, there's some submissions coming through. Okay. Perfect. Okay. Perfect. Okay, I'm glad this is what folks are saying. So a lot of disagrees. And hopefully everyone can read some of the comments because I think they're really important. So some things are, tending towards strongly disagree unless drug users are running the space in a compassion club model with anti-oppressive praxis. If they're happening within the medical system, then they're not outside of the institutionalized violence of the medical industrial complex. Not the exception. Perfect. Okay, next question. So safer supply programs do not replicate or amplify power and privilege as it exists in society. So I think based on people's responses already, I'm going to assume that a lot of people will, let me reread it for myself. Safer supply programs do not replicate. So a lot of people will disagree. Great, perfect. I think there's a, yeah. Thank you for engaging with the chat, even though Annotate doesn't work. Perfect. Okay. And then this one is more of an interpersonal or an internal question for everyone who's attending. So the reason why I'm asking this question is, can you gauge? So some people have a really good skill at this. Some others haven't developed this. This is a practice just like anything else. Do you know when you may have interacted with someone that made them feel dehumanized, marginalized, or excluded because of your actions or inactions? And this can be verbal actions, physical, whatever that might be. Okay, sometimes, not always. Okay, sometimes, perfect. Yeah. Yeah, and I echo what a lot of others are saying. Oftentimes, this is something that will hit me at the end of the day of like, oh, I remember that person. I caught them rolling their eyes when I said that ridiculously stupid thing that I knew I shouldn't have said. Or sometimes you can feel it in the moment when someone kind of shifts away from you and starts kind of becoming a bit more guarded because you clearly said something that communicates a lot to them in terms of what you understand or don't understand about their lived experiences. Okay, perfect. Thank you for engaging with that one. Okay. This is more just like kind of a pulse check for me, for the crowd that's here. How do folks feel about this one? I have a good understanding of how structural violence and oppression exists within the healthcare system. Perfect. Okay, great. Thank you, everyone. Okay. Perfect. Yeah, some folks are saying as a patient or not as a provider. And I think I would echo that your knowledge of it and your understanding of it is likely a lot deeper and more embodied than those of us who have gone through so-called professionalized training. Perfect. Okay. So I wanted to, I apologize for someone who's seen me present before because I feel like I end up talking about this tree almost every time. But I wanted to talk about this tree. So the reason why I'm talking about it is this is a little bit towards the any providers or clinicians, anyone trained in so-called professionalized healthcare practices here. You'll find that the branches of this tree are labeled what they call the social determinants of health. And the labeling of this and the reason why I share this is because this is often how people in different education, particularly healthcare education, are taught about issues of social justice. And I don't know if I can even stretch to say that, but this is often the rhetoric that's used. So people are taught that race and poverty and someone's income and unemployment status or the access to food or not is often what's linked to these downstream, what we would call health consequences that a lot of us are seeing as clinicians in our day-to-day practices. Neoplastic essentially just means cancerous in a simple way. So cancer and infectious diseases. And then you'll see here that when we talk about the social determinants of health, they're talking about housing. They're not talking about the fact that there are a lot of people who live in really large housing that exceeds their material needs. They're talking about gender, but they're not necessarily talking about heteropatriarchy. They're talking about race, not actually racism. They might talk about work environment, but they're not actually talking about the inherent exploitative nature of our economic system in terms of capitalism. Same with disability, as if this is an inherent thing. And so oftentimes when we're being taught about the social determinants of health, it's done so from this idea that clinicians and future providers need to learn about the so-called othered, vulnerable, at-risk communities. And it's done without actually ever having, I think maybe I won't make grand statements ever, but it's done predominantly in a way where they're not talking about power, and they're definitely not talking about history. So they might talk about, this is our housing crisis right now. This is how many people are experiencing, or how many people are unhoused in the city of Toronto. They're not going to talk about what historically that has looked like, what has been the historical processes of settler colonialism that have led to displacement, what are the historical relationships between capitalism and neoliberalism, current stages of capitalism, and the impact that that's had on housing. And the housing market. So there's often a very ahistorical understanding of it, and then there's often a very apolitical and particularly a lack of power conversation. So about that individual who's at risk versus all the individuals that make up systems that put that person at risk. And so when I was going through my medical training, this was really, really clear to me. It would stand out every time we were getting this teaching. And at the same time, prior to coming into medical school, I had somewhat of a foundation of the fact that there are much larger structures, there's much larger roots at the root of the issue, and we're often not talking about them. And through my residency project, so when I was in school still, I had wanted to really work on the cognitive dissonance I was experiencing as someone who was being taught a certain thing and seeing the exact separate thing being practiced within a clinical setting. And I wanted to look to see if there was any literature out there that actually looked at the relationship between these roots. And so here we're talking about the soil, the foundation of our country of Canada, rooted in the enslavement of Black people and the extraction of not just resources in the land, but also water and people, as well as settler colonialism and capitalism, which went hand in hand. And so within the roots, we've created these structures of hierarchy within society, which allows for ongoing domination and ongoing marginalization, and very clearly found that there was actually a lot of literature out there that made the links between these roots and what we'd call these downstream health consequences. But not so surprisingly, it was very strategic, and it continues to be really strategic by the structures and the powers that be, that we don't talk about these roots, because when we don't talk about them, we just allow the system to continue working itself. We allow the so-called social terms of health to continue producing downstream health consequences, which all of us as clinicians are then paid to take care of and support clients through. And that can continue to happen when we just keep the roots completely ignored in the process. So before going further, I just want to make sure we're all on the same page when we say the word oppression, because I know, the title of the talk has anti-oppression in it. I just want to make sure that we're all have a similar understanding of what we mean when we say oppression. So I'm hoping folks in the chat may be able to type in what their understanding of oppression is. It can be a few words, it can be multiple sentences, totally. Yes, please feel free to screenshot graphics, and we'll share the Prezi link as well. It's available online. Othering, yeah. Any other, control of a certain group of people by a dominant group. Perfect. Thank you. So yeah, structural, systemic, institutionalized domination of groups who are socially marginalized or forced out. Yeah. Exclusion based on social identities and unjust exercise of power. Thanks, Kelly. Perfect. Okay, so yeah, the us and them approach, which is a bit of a divide and conquer strategy, which we'll definitely talk about as well. Thanks, Nat. So really broadly speaking, oppression, like many have already put into the chat, it's when one particular social group or multiple groups dominate or disempower or marginalize or silence or subordinate another group for their own benefit. So there is an exploitation relationship when it comes to oppression. You are gaining something by subordinating, marginalizing, silencing, or disempowering someone else. It's often an unjust exercise of power, like others have shared, and it can happen through many different means. It's not just a physical, I'm harming you, I'm going to take something from you and gain wealth from it. It can also be psychological. It can be from a social threat framework. It can be cultural, it can be economic, etc. And whether the dominating group acknowledges it or not, I think it's important to just highlight that oppression is often happening because of an explicit ideology of superiority. And by that, I mean, people are, to themselves, whether they will admit it or not. So this is where the like unconscious or implicit bias conversations come in, which I don't really engage in because I think it's more a recognition of it or not outwardly. But I think people are coming from and practicing and engaging in oppressive behavior, whether it's at an institutional level or an individual level, because they think they know better, or because they think they are better, or because they think they have something that might be better. And you can understand how those of us who are trained within professionalized programs are essentially trained in order to oppress, right? We are trained to say that you have now gone through X and Y degree, you have gotten access to X and Y knowledge that other people don't have, and therefore you have something greater. And that gets extrapolated to a lot of us who then inherit the savior mentality. It's not just that we have more knowledge, it's that because we have more knowledge, we are somehow superior and therefore can inflict or force people into doing, etc., whatever we want them to do. And as others mentioned, we are, oppression is occurring at the individual level, and it's also most definitely occurring at the systems level. And so when we go back to this tree and what that looks like, I think I've spoken to this already, but at a systems level, what the soil of this tree is doing, the very structures that allow for Canada to exist in its current formation, is in order to enact control and to extract and exploit and wealth and resources, whichever way they can. And then they've built these hierarchies inherent to the soil. The roots are built in order to have people, in order to kind of utilize a divide and conquer strategy. So those who are and have more proximity to power will do what they can in order to gain some of the resources and wealth and control that others have, while further marginalizing others who are then lower on the social stratification based on these roots. And so here we're talking about transphobia, we're talking about cisnormativity, racism, ableism, heteropatriarchy, and imperialism at a global level, even though we won't be talking about the global relationship around the drug war today. And just wanting to highlight, since we're talking about the war on drugs and we're talking about safer supply programs, when we look at the ways that the healthcare system treats people who have been deemed by others to have quote unquote problematic substance use. So this may be others are making an assumption that the way someone is using substances is more harmful to them than not, or it's more harmful to others around them than not. Or that it's more harmful to the society because that person is then not engaging in the capitalist system and they can't extract wealth out of their labor. What we find repeatedly over and over again, and this includes through our drug policy, is a degree of disposability. So if we can't have you absorbed within our system in order to exploit you through that, then we will criminalize you and incarcerate. And that can include incarceration within prisons, within police, as well as within healthcare settings. Because if we can't extract from you within the mainstream system, then we're going to try to erase you, but ensure that we can still make a lot of money out of you. So if we think about the prison industrial complex and the amount of money and wealth that's created and generated for people who are within institutions, particularly prisons, you can see how the control and wealth extraction and exploitation continues even when people are in prison. The other point that I'll just make here is just that, we've continued to use our drug policies in order to enact this vicious cycle of violence. And it's this very kind of Euro-Christian idea of if we just, because substance use in a way that's deemed problematic by the society we live in is an issue of individual quote unquote failing, we will punish people, we will make people hit rock bottom, which is often language you'll hear, including in clinical offices. But if we push people into feeling bad enough, we will somehow get them to change their mind. And so again, recognizing it's just fulfilling this prophecy that the system has created in order to continue to maintain itself. Okay, what I was really interested in and what I'm hoping to share with you is oftentimes we'll talk about the roots of the tree as if, recognizing that the roots of this tree definitely exist within our so-called prison justice system, or they may exist within education. But I find within healthcare settings, it's often seen as, healthcare spaces are ambivalent. This is where people who are altruistic will come in order to provide care for other people out of the goodness of their hearts, et cetera, et cetera, et cetera, without really thinking about how the roots of this tree have been deeply embedded in the history of our medical system across North America. And so this is why I wanted to share a few examples with you today. And I'm flagging it as a content warning. So particularly for those of you who may belong to the communities of people that we're talking about through these examples, please feel free to step away and do what you need to do, maybe for the next, I would say, 15 minutes or so. And for those of us who may not necessarily belong to communities, and particularly I'm talking about Black, Indigenous, other racialized communities, queer and trans people through these examples. So if we are not necessarily belonging to the communities and you're experiencing a lot of discomfort while we go through these examples, I encourage you to try to stay with us as much as you can, because I do think that there's a lot of power in discomfort. And I think in order for any of us to shift and grow, we have to feel discomfort within our bodies in order for us to actually have an embodied understanding of what it is we're trying to then dismantle and change to create something better out of. So hopefully that makes sense. So recognizing that discomfort is not the same thing as safety, and trying to stay with us if what you're feeling is uncomfortable, not unsafe. Okay. Does anyone recognize who this might be? Let's see if anyone in the chat does. Tommy Douglas, yes. I've just noticed the more, depending on the age of the crowd, because I have done a similar lecture to medical students who are younger. They don't necessarily recognize who this is, which does make me feel older. But I'm glad others are able to recognize that this is Tommy Douglas, father of Medicare, et cetera, et cetera. And I'm not sure how many of us, for those of us who have gone through professionalized training, actually learned about Tommy Douglas's work, particularly around eugenics. And so when I say that, what I'm talking about is in 1933, Tommy Douglas published his master's paper. He graduated at that time. And his master's paper was titled Problems of the Subnormal Family, I believe. And essentially he looked at what he proposed as eugenic solutions, such as segregation and sterilization, to limit the spread of quote unquote subhumans, who he defined as women who engaged in sex work, people with disabilities, people belonging to the LGBTQ community, and of course, Indigenous people. And, if this was just one person's master's paper, that's okay. Let's see how he shifts, because later in his career, he does actually apologize for the work that he did. But the same year that he published his master's paper was also the same year that BC actually passed their Sexual Sterilization Act. So here I'll show you the first page of the act from Alberta. And a couple of years before then, in 1928, Alberta had passed their Sexual Sterilization Act. And in brief, we won't go into a lot of detail, what I will say is that this act involved a psychiatrist, a judge, and a social worker who made up what they called the Board of Eugenics, and they oversaw the mass sterilization programs in so-called residential schools, as well as in quote unquote Indian-only hospitals, as well as other spaces within their provinces. Similar work happened in BC, and these acts remained in place until the 1960s. So not that long ago. And then I encourage people to read this book by Karen Stoll. It was published in 2015. And Karen Stoll talks here about how the targeting of Indigenous people continues well into the 21st century. And this book was published in 2015. And so up until that point, she had studied the 1970s and found that there had been over 580 sterilizations of Indigenous women that had taken place in quote, federal hospitals across Ontario. And so that includes hospitals in places like Moose Factory and Sioux Lookout, where a lot of us actually go and do our training in present day as well. Okay. how many people have heard of the term Drapedomania? I hear, yep, yes, okay. Yeah, Samuel Cartwright. Okay, good. I won't go into too much detail. But for those who haven't heard of the term drapedomania, this was one of the earlier diagnoses in the medical establishment, the medical system in Canada, sorry, not in Canada, all across North America. And here, this was coined by Samuel Cartwright, who was a surgeon, and he published this in the New Orleans Medical and Surgical Journal in 1851. And here, essentially what he was describing is a new diagnosis that he's found. Mind you, he was also someone who had enslaved Black people who he was exploiting their labor from, and was ran a plantation. And in his paper, he talked about how enslaved Black people who were trying to attempt to escape from slavery had what he termed a medical disorder, which he called drapedomania. And he said that with proper medical advice strictly followed, the troublesome practice that many enslaved Black people have of running away could almost entirely be prevented. He put out prescriptions for this so-called disorder, which he included things like you have to whip the devil out of them as a preventative measure. And he also suggested the removal of people's large toes in order to make running a physical impossibility as a preventative measure as well. And so, this is the 1980s and people in the early 1990s. And sometimes people will say to me, well, Nanky, that was early times. This isn't the stuff that continues into current day. But we know that anti-Black racism, particularly within medical establishment, has continued and remains pervasive into present day. This here is a photo from a commercial done in a psychiatric journal. And here, this is where in the 1960s, when a lot of Black power movements were on the rise, psychiatrists decided to come up with a new diagnosis called the reactive psychosis. The other term for it was called the protest psychosis. And what they said this was, and I'll quote one of the articles here, where they said a Black youth who was diagnosed with psychosis was someone who was influenced by social pressures, such as the civil rights movement, and is someone who is guided in content by African subcultural ideologies and colored by a denial of Caucasian values and hostility thereto. I encourage you to read a book by Jonathan Metze called Protest Psychosis, How Schizophrenia Became a Black Disease. This book was published in 2011, I believe. And here, Jonathan Metze really traces how this new psychotic illness that was developed in the 1960s was later replaced with a rise in the diagnosis of schizophrenia among African-American men, and particularly youth in the US. And this here is the commercial that I was talking about. This was published in 1974 in the Archives of General Psychiatry. And here they're showing you someone who is quote unquote meant to be assaultive and belligerent. It's a commercial for Haldol, which is an antipsychotic to try to suppress their aggression towards the healthcare system and also towards society. And the book is called, I'll put it in the chat. It's called The Protest Psychosis, How Schizophrenia Became a Black Disease. Let me see if I can get that in there. All right. No, the other thing that I just wanted to bring up here is, we often look towards people like Harry Anslinger and the Nixon government for their, creation of the racist war on drugs. But I just wanted to highlight, renowned Canadian feminist judge Emily Murphy. And I'm not sure how many people have heard of or read the book that she published in 1922 called The Black Candle. And the reason why I wanted to share this book and encourage you to read or listen to this CBC interview, but the reason I wanted to share it is because right prior to that, in 1908, when the first Opium Act came into being in Canada as a result of anti-Chinese xenophobic riots in Vancouver. Won't go into details, but I encourage you to read it. There's a lot of documentation written about this. And then, a couple of decades later, in 1922, Emily Murphy publishes this book. And the kind of premise of this book is that people, so racialized people around the world, have created a conspiracy and they've banded together to try to corrupt the purity of the white race with the help of drugs. And essentially that's really what she's promoting. And what she's promoting is that Black and other non-Black racialized people should be deported out of Canada in order to prevent the intermingling and the lack of purity of the white race from being able to continue its project of settler colonialism. And a lot of historians actually account to her publication of this book to the expansion of our drug laws in 1923, where heroin, codeine, and cannabis were added, because she focused a lot on heroin, particularly cannabis, in her book as the drug that was being used by racialized people to corrupt, again, the purity of the white race. So I leave that to you just so that we don't continue to just look south of the border to find origins of the racist war on drugs. There are ample examples in all of our drug history here in Canada. I will share this book by Gary Geddes, largely because I wanted to flag, where we're talking about pathologizing people as a result of issues of justice. And, how is that related to the healthcare system in Canada? I would encourage you to read this book, because I find one of the things that really stood out for me was Gary Geddes talks about how, as new settlements expanded in Canada, as settler colonial was expanding and more land was being stolen, the quote unquote Indian agent who was within these communities was often also the same person as the local physician or healthcare person that was meant to provide care for the settlers who were around. And these people actually had the authority, which continues in our public health laws today, to be able to incarcerate anyone that they deemed would be a threat to the white settlers who were expanding and stealing territory. We recognize how Geddes really talks about how the healthcare system, particularly clinicians who had the power to be able to detain any Indigenous person that they thought was a threat. And so they would use things like, risk of TB or risk of other infectious communicable diseases as to why they're detaining the person, but they didn't have to actually have proof that why they were actually detaining them or not in these so-called Indian-only hospitals. And they talk about how the healthcare system really enforced what they call terra nullius, right? This idea that the land is quote unquote unbarren because it's not habitated by white Christians and therefore for the taking by the crown. And so in order to actually have the land quote unquote be barren, Indigenous people were actually literally removed from it through the work of physicians in incarcerating them because of a threat of infectious risk to the white settlers who were coming. So I'll leave that example there. Oh, time. Okay. I'll go through these briefly. I imagine many have heard of some of these experiments and studies already, but if you haven't, please feel free to check out the link. They're all available online. But the bottom here is a medical instrument that all of us still use if you're ever in the OR. This is an instrument that's called the Sims Speculum, and it's coined after Miriam Sims, who was one of what we would call the father of modern gynecology. And Miriam Sims actually developed this speculum and became so famous in part because of the research he did on enslaved Black women who were under his control. And he provided surgical, he operated and did a lot of experimental surgeries, particularly around vaginal fistulas on enslaved Black women without giving them any anesthesia, because again, this assumption that quote unquote Black people feel less pain or are not needing anesthesia or any pain treatment while he was doing these experimental procedures. At the same time as he was doing them, he was then perfecting those surgeries and then doing them on white women and people with vaginas, and would often offer them access to pain treatment in order to ensure that they were comfortable through the process. And the legacy continues today. There's a lot of particularly Black feminist organizing and resistance to really take down his statues, because they exist all over North America as well. And then this article here by Kelly Hoffman and colleagues that was published in 2016 really looks at the fact that it's not because, quote unquote, Black people have other coexisting comorbidities like poverty or other reasons as to why they get less pain treatment, because that was their justification, that because Black people are more likely to be poor in the US or more likely to have a history of substance use issues, et cetera, that's why they don't get opioids for their pain treatment when they come to emerge in emergencies. And then they found, when they actually did studies with medical students and residents, that the rationale rooted into all of it wasn't just these social realities, but it was also the fact that majority of the white medical students and residents actually believed in a lot of the pseudoscience and fake science that was created in order to justify slavery. So things like Black people have shorter nerve endings, have thicker skin, et cetera, et cetera. So a lot of people in present day continue to believe that as clinicians. And, consciously or subconsciously, this is also part of what actually deters them from prescribing appropriate pain management when people are being seen. And then, of course, we know that the dehumanization of people and, seeing people as less than full human and therefore harming them continues until present day. I was really surprised. I hadn't heard about Stephanie Warner until late last year, when a colleague of mine, Matt Johnson, had actually done a presentation with us. And Stephanie was someone who was waiting in an ER at the Toronto General Hospital, just up the street from where I work in clinic. Last year ended up being restrained by the hospital security guards and killed. And in the process of the restrainment, security officers were seen to actually move the cameras away. And so there's no account of what they actually did to her. And people talked about the fact that she was waiting there patiently, but this was someone who had been identified as someone who was experiencing homelessness and was someone who was using substances. And, recognizing all the reasons as to why the security personnel and healthcare workers around them not intervening, felt that they could actually physically dehumanize, restrain, and kill this woman without any consequences. And that continues to be the case. The coroner deemed her death I can't remember what the legal language was, but it was not deemed a homicide. Okay, why am I sharing all of this with you? So part of the reason why I wanted to just share all of this was that in the report that I had written, which I encourage you to read, it goes through these in a lot more detail. Really, when I say medical violence, what I'm trying to summarize is that the roots of the tree that we've been talking about continue to show up in lots of explicit and implicit ways within clinical practices. And some of the more structural ways that they continue to show up is through forced, attempted genocide, so eugenics, which continues in much more subtle ways in present day, through medical experimentation and through dehumanization, and through medicalizing issues of social injustice and denying that structural violence actually exists. And we can talk about how this occurs particularly against people who use drugs for the whole rest of the time we could, but instead I'll just encourage you to check out this resource if you haven't. I imagine many of you who are here today already have, but if you haven't, I encourage you to listen to Crackdown, especially their episode on methadose and their most recent episode on Suboxone, to try to think about how these different ways that medical violence continue to show up are explicitly coming up over and over again against people who use drugs, and particularly drugs that have been criminalized. Okay, so part of the reason for why I'm really sharing any of this is because I think the fact remains, it's not just that we may hold consciously or subconsciously may think negatively or inferiorly about other people. It's the fact that those of us working within the healthcare system actually have institutional backing and political power to act in oppressive ways without limited public knowledge, let alone scrutiny or consequence or accountability. And so hopefully this quote kind of rings true for a lot of people and helps you reflect. You can also Google and find the entire speech that Stokely Carmichael made in the 1960s. It's a really important read. Okay. So here's some of my thoughts of what I continue to think about and continue to shift in terms of what to do from here, right? Understanding that medical violence exists, understanding that the roots of the tree are deeply embedded within all of our institutions and society, including the healthcare system. And where do we go from there? I think importantly for me, this quote from Octavia Butler has always been really helpful. Where, here she says, all that you touch, you change, all that you change changes you. And I think for me, the reason why I share this quote is that because we know oppression manifests itself from the internalized all the way to the interpersonal, institutional, and societal level, I think it's important, and I think it behooves us to recognize that whenever we're engaging in resisting medical violence, we have to do that at all 4 levels simultaneously. And that might shift based on our own personal skill levels and what brings us joy and what we like to do. But I think it's important to recognize that we can't just critically think internally amongst ourselves or with just the handful of people who are close to us without engaging in radical change making work at a societal level. And we also can't just focus on external, societal level changes without ensuring that we ourselves are also changing and growing in the process. And at the interpersonal and at the internalized level, what's been really important, and I brought up discomfort before, is this idea of really embracing the discomfort and dissolving guilt, because I do find guilt is a really self-serving emotion, very common one. All of us experience it all the time. Usually when critiques are brought forward with the healthcare system, majority of us, and including a lot of providers and clinicians, our gut reaction is to be defensive and to experience, be defensive because we're trying to dissolve our guilt and try to deal with it. But instead, I'm really hoping that we're able to actually answer that question I had asked in the beginning in terms of practicing the skills that we need in order to know when the assumptions that we hold, the attitudes that we have, and the ways that we are behaving may actually indeed be marginalizing, excluding, or dehumanizing someone else. And, oftentimes this is called self-reflexivity when we're talking about education in the healthcare system. But I would say, for me, when we talk about self-reflexivity, it's this idea of having to do the work to really process through, to try to break down our own understanding and think about our privileges. But my main thing really to contribute to that is that we can't do this in isolation. We can't do this work in terms of gauging our skill level around picking up the ways that we may dehumanize other people at an internal and interpersonal level without actually talking with other people and being open and critically looking at the way that we have structured our communities, our clinics, our offices, et cetera. And I think part of this for me also means looking at the language that we use. And I think that that's important always. I think, I appreciate that. Yeah, guilt is an obstacle to taking responsibility, and taking responsibility is a prerequisite for change. And I often like to break down the word responsibility. For me, responsibility is response and ability. So what do we have the ability to be able to respond to? And we have to commit to actually responding. And when and if our abilities shift, our responsibility shifts alongside that too. So thank you to the person who put that in the chat. I can't remember what I was saying. Oh yeah, so language is incredibly important. And I think part of the reflection and the reflexivity piece is also really thinking about whose stories you're actually listening to. Who are the people who are actually coming in and feeling comfortable seeing you in your practices? Who's actually missing, who's getting policed, whose histories are surviving. I think these are really, really important things to think about when we are practicing on a day-to-day basis. And oftentimes part of the guilt can also be coming up with these justifications that, I don't have time, my hands are tied, the structures that are the way they are like that. And I think really part of the embracing the discomfort piece is actually working towards figuring out where that initial reaction of my hands are tied, I can't do anything about this comes from, and working to actually challenge that amongst ourselves as well, in order for us to not actually be gatekeepers to institutions and services and health knowledge and care, but instead actually be care workers. And I really like this quote from Sophia Bartlett where, because Alison Baker had posted about how, love when people talk about barriers to treatment as if many addiction services themselves aren't their own deterrent. Not all help is helpful. And some help is hell. And I think that's, I think all of us can probably think about a lot of people who have shared that with us, or people here who have obviously experienced that life. And Sophia here talked about, my favorite is people who talk about hard to reach patients. How about we flip that around? What about hard to reach doctors, or hard to reach services, or services with crappy barriers and restrictions on access, or doctors with shitty attitudes, which again, I think brings up to really shifting the conversation around reflection when we're having these conversations about times when we may have harmed other people. At the clinical level, like at the interpersonal level within our clinics, I think for me, what's been really helpful as a framework is really understanding that my role there is to practice healthcare as an act of solidarity, not charity. And when I say solidarity, I don't mean just experiencing sympathy for other people. I mean genuinely showing up as someone who is invested in dismantling the institutions and the power and resources that they hoard, and moving them towards those who are most at harm's way from structural violence in our society. And this quote here by Monica Tula, hopefully you can read it. I think for me, this is the essence of Safer Supply in terms of why I'm doing Safer Supply. I do not think Safer Supply is where the liberation is at, particularly in its medicalized model that many of us are practicing in. I solely really practice Safer Supply because trying to support people in actually staying alive, and not just staying alive, but support people in being able to organize with others around them and get access to power and resources away from institutions that are continuing to harm them. So hopefully that resonates or makes sense. I'm going to skip some of this for sake of time, so we have lots of times for conversations. I wanted to just talk at the institutional level about why I think our history doesn't have to be a legacy. And I think the only way that that can be true, so when I'm talking about history, I'm talking about all of those examples of medical violence that I went through. That is the legacy we're inheriting, but it doesn't have to continue to be. And I think this is where organizing ourselves within our workplaces and also outside of our workplaces, because there are going to be inherent limitations to what we can do within them, is really important. And I share the 8 white identities framework from Barnard-Hess because these are so you can use this on whiteness, you can also use this on lots of other forms of oppression. But here, these are all actionable items. All of us exist in one of these places, one way or another. Either we are actually holding on to our supremacist ideologies, or we're starting to get to the place where we're being critical of the dominant oppressive ideology, whether it's whiteness or whether it's something else. Or we're starting to shift beyond being critical towards becoming traitors. And I think people are often will police how people engage in resistance. And I think it's really important for us to actually engage in ways that works for the communities around us. And actually work towards becoming not just traitors, but moving from being traitors to our institutions towards actually being abolitionists. So working towards dismantling the ways that we structure our clinics, the ways we structure our practices. Our goal should be working ourselves out of our current role and out of our current jobs. If our jobs are reliant on making money off of the ways structural violence harms people on a grand scale. And when I say that, a lot of people are like, but I love being a doctor, I love being a nurse practitioner, or I love doing this. I don't think there will ever be a place where your role and the care work that we can provide is not going to be necessary. I think the difference is I would love to support people with, potentially, I was going to say high blood pressure, but often environmental racism and so many other factors also lead to high blood pressure. But, I would love to support people in doing preventative care and doing their Pap tests, supporting them and seeing if they develop diabetes or not, as opposed to continually trying to support them through for issues that are really, really rooted in issues of justice that we as a society and as a community need to dismantle. Hopefully that makes sense. Okay. In terms of at a societal level, so this is the piece that I was saying that I think we can't just do this work interpersonally or within our clinical spaces. We have to engage more broadly with the ways that grassroots movements for justice are demanding change to happen. We have to support and uplift struggles for Indigenous sovereignty and Black liberation in particular as well. And I think for me, what that means when I'm as a clinician, as someone who's operating, is to ensure that the work that I'm doing actually centers the margins, because everything in healthcare is very much rooted in proximity to those who have power. And, so for example, we'll get a new technology made in healthcare, some new screening test or X-ray machine or whatever. And then usually it's followed up by 10 years of research as to why X and Y marginalized groups can't access that new technology or new therapy or whatever has been created. And if we actually flip that completely and actually center the perspectives and experiences and solutions coming out of those who are most pushed to margins of power within our society, a framework brought to us by Black feminists like bell hooks, and as well as third world feminists like Chandler Mohanty here, I think you can think about how then, if our solutions are coming from those who are most pushed to the margins, then the solutions that we create will inevitably also support others who are then closer to proximity to power. An example of this is how the healthcare system responded to a rise in overdose deaths by curtailing high dose opioid prescriptions on the ODB formulary. And so we can't prescribe high dose fentanyl patches, we can't prescribe high dose injectable hydromorphone, because this was the healthcare system's way of responding to their own sense of obligation without actually asking those who are most at risk of the war on drugs and most harmed by the war on drugs around what the solutions could be. Okay, I definitely wouldn't want anyone to walk away from today with thinking that medical violence has continued to happen without any resistance to it. I think it's really important to acknowledge that communities who have borne the brunt of medical violence have always been at the forefront of resisting it and have been often criminalized as a result of resisting it. And that continues until present day. And that oftentimes the communities who are engaging in this resistance work have not just improved the health broadly at a community level for the communities that they were fighting for, but have also improved the health for many others. And so example of here is a photo of the Black Panthers doing their sickle cell training program. And in the 1970s, the Black Panthers, I think the estimates are somewhere about tens of thousands of children and people were actually screened by the Panthers nationwide, and it shamed the Nixon government at the time to pledge millions of dollars into sickle cell diagnosis, and it created the Sickle Cell Disease Association of America as we know it today. There's lots of critiques on why Nixon did that. I think part of the reason for actually putting a lot of that funding towards sickle cell disease at the time was to actually try to strip away power from the Panthers, who were such a threat to the nation state. But that's a conversation for another time in terms of how resistance struggles are co-opted by dominant institutions, including safer supply programs, which we can talk about. Here is a photo from the Young Lords. The Young Lords was a grassroots organization made up of Puerto Rican migrants. I listened to a podcast recently and I was blown away that the Young Lords were actually people who were aged 13 to 18 predominantly, which I just incredible in terms of the work that they were able to do within their communities. And here is a poster because the Young Lords decided to take over Lincoln Hospital after they found out that children who were being admitted for different issues were coming out of the hospital with lead poisoning because of how poor the facility was. And this was Lincoln Hospital is a major hospital serving the South Bronx and East Harlem in New York, where a lot of the Young Lords also lived and organized. And so they decided to take over the building. They had 200 healthcare workers who were in the emerge actually stayed with them in the occupation. And these were some of the demands that they were asking for. I'm not sure if you're able to see them here. You can definitely read a lot more about them, but included things like minimum wage for all workers, childcare center, support for treatments like NADA, which is an ear acupuncture protocol for people who are going through opioid withdrawal, which was something that the Young Lords actually pushed forward to try to bring into the healthcare system in the Bronx at the time as well. And then here is an example of ACT UP. Here's organizers. So this is AIDS Coalition to Unleash Power. organized a lot and pushed for access to ARVs as we currently know them. This is them actually doing a die-in outside the FDA. And this action, amongst many others, actually pushed the FDA to release a lot of the new drugs that they had been working on into the market, so that the early days of AIDS medication called AZT wasn't the only option that people had available to them when they were dying of HIV. And of course, we have frameworks of compassion clubs where people with HIV started coming together, lumping medications from each other when their loved ones were passing away, in order to also provide mutual aid and support for one another. Examples that a lot of people who use drugs and harm reduction activists also utilize to come up with creative solutions in present day. Here's an example of Moss Park. A lot of harm reduction workers here in the city that I'm in Toronto, taking up tents in a park where there's a high overdose rate in the city. And this was done because the bureaucratic delay around funding for the first 3 supervised consumption sites was continuing to happen, and people were dying of overdose at an accelerated rate, as they have been for quite some time now. And erecting these tents and actually operating it for as long as they did in itself, and it was, a powerful experience where people who use drugs got to build their power collectively. But at the same time, they also pushed the province, shamed the province into really releasing the funds that the 3 agencies needed to actually enact the first sanctioned overdose prevention sites. We've got safe supply concept documents coming out of CAPUD, the Canadian Association of People Who Use Drugs. I see a number of the members here in the chat. And so here's people who use drugs actually coming up with ideas and solutions on how to address the war on drugs. And it, influencing many of us, including myself. This came out in February 2019, which is the same month that I started prescribing safer supply. And then more recent action by DELF, the Drug Users Liberation Front in Vancouver, where they're really challenging what it means to actually have access to safe supply that is not a medicalized model. Their demands include having accessible legal framework that decriminalizes, licenses, funds, and provides facilities for people to have spaces for heroin, cocaine, and methamphetamine compassion clubs, and for the government to immediately fund programs for safe and accessible supplies of all drugs, including cocaine and heroin and crystal meth, by directly listening to user groups and people who use drugs and adding these drugs to the formulary, or allowing drug users to actually create their own routes of access. And they've had some incredible actions where they've actually handed out tested drugs through collaboration with Vandu and many other organizations as well. So point really is, oftentimes people will ask, like, well, what do I do at a societal level? Just important to remember that communities who are resisting, at the front lines of resisting the war on drugs, are coming up with solutions, have always been coming up with solutions. So the question for ourselves is really thinking about what your skill set is in terms of how you can rematriate those skills or knowledge back towards the grassroots communities who are engaging in resistance on the front lines. And sometimes I share the example of the young lords stealing an X-ray TB van because they weren't doing TB screening for the community members where they lived. And so I always think about who was the X-ray technician that taught the young lords how to actually run the machine, and how can we be that person? Like, what are the skills tangibly that we have as clinical providers to be able to bring that into the hands of communities who are resisting? Because ultimately we need to be able to support self-determination, which I think is a necessary prerequisite towards health and full healing and collective liberation. And ultimately, final message really is, it's critical reflection. We need to be able to critically reflect, often do that with each other. And we can't just stop at the reflection and the unlearning and learning. We have to actually engage in informed collective action. We have to make mistakes. We have to learn from those mistakes. We have to shift our strategies. We have to try, 100 different things. And that doesn't mean you as an individual needs to try 100 different things. We need to support all of us in engaging in ways that make sense for us. And that brings us a lot of joy and restoration in the process as well. And that's what's really needed in order to build actual social change. So I'll leave it at that. Any questions? And I can stop share screen so I can see all of your faces. I think I see a hand up.
Nanky, would you like people to use the question and answer or just in the chat? What's easiest for you? And we're watching.
Chat's good. Yeah, whatever.
Okay, great. Thanks.
Thank you for your kind messages, everyone. I'll share the Prezi link so everyone has access to it as well. I know, Rebecca, you're going to probably be doing some kind of evaluation. I'm sure my managers would also want me to do that, but I will leave it to you to do the evaluation pieces.
We will, and we'll share them with you, Nanky. If it is okay, I'd like to just do a really quick poll. That is partly for our funders, also to see our reach right now. And so while I do that, people can have a look at, think of some questions or discussion points that you'd like to discuss with everyone. Because I think it is a really thought-provoking presentation, and we can also have some more talk like in the future about this. I think this is ongoing work, as you said, Nanky, and we need to keep this stuff on the agenda all the time, which is why we've started the National Community Practices started with this presentation with Nanky.
Yeah, no, I'm happy to answer any questions that come up for folks and share thoughts, because I do think that we're constantly in a contradiction for those of us who are working in safer supply programs. I think, especially as many of us get Health Canada funding, I've been reflecting a lot about how power constantly reorganizes itself to retain power. And so when governments are giving a handful of funding to safer supply programs, in the process, they're also absolving themselves of actually working towards abolition and defunding and decriminalization, as well as regularization and legalization of drugs. And so, part of that is why I think for those of us who are working in safer supply programs, it's such a important responsibility for us to actually continue working alongside people who use drugs and grassroots organizations in actually demanding for full decriminalization and legalization, as well as abolition of prisons and police, as some fundamental necessary changes in order to actually address the overdose crisis.
Thanks, Kayla. That's really important. There is a question here from, who did I say, Malika?
Sorry, I'm like interrupting your poll, Rebecca.
Okay, that's okay. I'm just looking. There's so many wonderful comments thanking you for this presentation, Nanky. Okay, there is a comment here from Malika Sharma. Nanky, can you comment on how to push this critical understanding of medical violence in places that have been structured to be removed from community, like hospitals and patient care, often the biggest enactors of violence? Thanks, Malika.
Yeah, thanks for that tough question, Malika. I think, so I'm always of the opinion, so oftentimes people will say like, well, do you work in the system? Do you work outside of the system? And I definitely feel like for those of us who are in these institutions where a lot of power is hoarded, and particularly in hospitals where clients who are coming in who are being hospitalized are also at their most exploitable, right? Like they're constantly being exploited. They're being poked. They're being woken up at any hour of the day. Their humanity is not actually part of the conversation. It's very much this transactional delivery of health care, if I can call it care. And not to say that incredible clinicians like you, who as a person who asked the question, don't exist within those spaces, but I think this is where having conversations with your colleagues and building relationships in smaller groups of people to build that critical analysis together is going to be so important. Because I think you have to be a little bit covert before you can actually get your entire institution to shift. And you have to build alliances with a lot of people who you may expect to be aligned or others who you may not, but really finding those people through all the nooks and crannies of your hospitals in order to come up with all the strategic ways that you can to push leadership within these institutions to do the bare minimum, but also remember that changes from the top down aren't going to be sustainable if the actual people carrying out the care work, the healthcare delivery, are not actually aligned with what the changes are meant to be. So you could have a supervised consumption site and people coming in, and people could then just be treated like absolute shit. And it's not going to, by the actual people who are physically in the supervised consumption site delivering that care or checking people in. And it's not going to actually meet the purpose of what the organization was trying to do. So I think it has to be a bit of this two-pronged approach where you kind of build the critical consciousness of colleagues around you through every and any way that you can, while continuing to then, you know, in all your directions that you have access to, push for larger changes at the top. Hopefully that works. And definitely, I think organize with people outside of your institution. I think this is where the being traders and working towards being abolitionists really comes in. Like, leak things to people outside, like give people who are resisting your institutions the knowledge and the resources and the information they need in order to put the pressure on externally, which you yourself can't do because of the implications that might have for your livelihood. And so be strategic in that. Don't publicize it. I can say it in this presentation, but I think that is actually a really important skill that we should all have. How do we actually genuinely support the leaking of information and resources and skills towards communities? Yeah, Allison asked a good question. I don't know how much time we have. I'm assuming we have till 1:30. So Rebecca, if you're okay with it, I can respond to that.
That's great.
Yeah. So since 2008, I've done a lot of workshops to try to change the oppressive discourse, yet I see time and time again, participants 100% agree on the concepts, yet in practice continue to oppress and stigmatize people. Do you feel that at some point there has to be some type of accountability as opposed to education? Yeah, 100%. I oftentimes, and when people think about accountability, they're thinking punishment, but I think it's important to separate those out. I think accountability should be a necessary part, and I think there's a very limited lack of accountability within our healthcare institutions, and I think we can't do this work without actually building strong accountability processes, because you and I could have this conversation all day long. I could actually go and treat someone like absolute crap in our clinical appointment, and no one will actually have knowledge of that. And this is also part of why I think being in a safer supply program, one of my responsibilities has also been to ensure that the clients I'm working with do get access to organizing with each other. Obviously, COVID has really disrupted that, but having drop-ins where clients are talking amongst themselves, having advisory committees where the prescribers are not actually present for all of the conversations, so that people can actually strategize and build conversations together and build structures of accountability that will actually work, as opposed to just slapping an idea of accountability that the institution thinks is enough too.
There's a question in the Q&A. How can we create a culture within our workplaces that welcomes disruptors and people who speak out against power hoarding in medical teams? The person feels like I'm risking my job, labeling myself as insubordinate when I advocate in a way.
Yeah, this is a tough question. I am lucky in that I work within an institution where I at least know that my executive director is open and fully knowledgeable about who I am as a person before I was hired. And so it's harder for me to answer this because I will risk a lot of things. And one of the responses I've had from my leadership is that part of hiring you also means that we have to be open and willing to shift, because I know that this is going to be a challenging relationship one way or another. And I think that's actually really helpful. This, both people who admire each other, but also can acknowledge that there's going to be challenge, there's going to be conflict, and we have to work through it. If you are not in that situation, I think you do have to be very strategic. You have to be mindful of how you're organizing meetings, where you're organizing meetings, how you're working with your colleagues. And you have to be just a bit more strategic in terms of the ways that you're asking for change, whether within your institution or externally. So similar to, I think, what I was saying to Malika. So just depending on how open the leadership is of where you're working, will depend on how you would, I think, utilize different tactics to address it. Hopefully that answers.
There's another one from the Q&A. Prescription-based models of safe supply transfer the risk to prescribers and away from government and regulators. How can we advocate with regulatory colleges to become part of the solution instead of hoarding power over prescribers?
Yeah, that's a good question. I think for me, I think this is where it's been interesting to see how the regulatory colleges have responded to safer supply, because I don't think any of us who were prescribing anticipated, for example, the CPSO to come out acknowledging that safer supply is happening, and here's the parameters with which we hope you do. And I think when that shifted, there was a little bit of a, yes, it's helpful for those of us who are prescribing to not feel like we're going to be constantly on edge of having our licenses being taken away. But I think there was also a little bit of this absolving themselves of responsibility that's happening also at the government level. And I think part of the pushing of that is to continue to focus on broader societal level changes, because I genuinely think our regulatory bodies are going to be the last places where change happens. Others are responding to it. And so oftentimes people will say, we need to really struggle to make the change happen. And I think I'm of the mind that we need to actually find other people who are more aligned to us at a broader societal level and work towards increasing our overall collective power, as opposed to going to those who are going to be the most in opposition to what we want to do and wasting a lot of our time and resources in trying to shift them. And I think hopefully that helps with the work that you're doing. And I think, they will definitely need external pressure from many directions, not just from prescribers. But I think this is where we need to have policy level shifts at a governmental and institutional levels. I often share the spectrum of allies framework, which has been really helpful in organizing for me as well, to try to think about who are your direct opponents versus who could be allies and somewhat allies, and really nurturing those who are more aligned. Folks can look that up if that's helpful. Any other thoughts or questions? I mean, I also say this with the grain of salt, is this is my, the theorizing that I have found to be the most helpful. And there are many different change-making theories and practices out there. And so I think doing the work and actually learning about them is also really important for those of us who are engaged in not just providing clinical care, but also engaged as political actors in the world. But hopefully some of these resources are helpful for you.
Nanky, let me say a deep, deep thank you for this presentation and for starting us off in such a great way for this National Community of Practice. If there's any other questions for Nanky or comments that you'd like to make in the chat, that's great.
I did see a hand up from Emma. I'm just not sure if they were able to ask their question. And yeah, thank you, Gabrielle, for, yeah, they've been translating and really, really appreciative. Oh, okay. Thanks, Emma.
I'm just going to share my screen to tell you a little bit about what's coming up. So we would like to invite you to check out our new website. And if you are currently a member of the community of practice, we would like to ask you to register on our website. So we have you registered as a member, and we'll make sure that you get to continue to receive all the information and access to resources and all of that. If you're not a member, we would love to have you join us. There is, again, you just go to our website and there's a join page there. So you just join there. We're also now on Twitter, Instagram, and Facebook. So you can look for information from us there as well. So we have some upcoming public events, and then we have some upcoming members only events and some resources that we're going to soon be making available to our members. So public events, we've got Corey Ranger, who's an RN at the Victoria Safer program in Victoria, BC. Corey's going to do a presentation about Safer Supply 101, and we'll be sort of providing a bit of a background and situating Safer Supply, including the medical models, its limitations and such within the current discussion around Safer Supply. So that's happening next Thursday from 12 to 1. Hope you can join us. Please do register in advance. To register, you can also find all these links on our website. And then November 8th, Corey Ranger and Akia Munga are going to do a talk about emotional harm reduction. That is happening from 1 to 2:30 in Eastern, it should be Eastern Daylight Time. It'll be that by then. And then on November 25th, Jillian Kola will be presenting the London Intercommunity Health Centre's Safer Opioid Supply Program Evaluation. And that again is 12 to 1:30. And in terms of member only events and resources, as I say, you do need to register to be able to access these things. We have a prescriber panel that's going to be happening December 16th and talking more about these tensions that arise for prescribers trying to offer safer supply from a harm reduction approach, but also working from within the medical model. We are going to be launching a prescriber consult line within the next couple of weeks. So stay tuned for more information about that. If you are somebody who prescribes Safer Supply, you do need to be a member of the community of practice. And then you also need to register as someone who can participate in the consult line. We have more information for that coming out. Just feel free to reach out to us. And then we are in the process of organizing some role-specific workshops around Safer Supply. So that's coming in January. We've started some working groups on topics such as diversion, securing access to pharmaceutical alternative, or sort of just pharmaceuticals rather, employing people with lived experience. And then we also offer consultation and support. So we've had some workshops on funding applications and provided some assistance with funding applications, as well as connecting people and talking about program development, policy development, that sort of thing. So yeah, hope you'll join us. You can contact us through the website and get information there. But on behalf of the team, the organizing team, the National Safer Supply Community of Practice team, I'd like to, my big thanks to Nanky and Gabrielle, and to all of you for joining us today.
Thank you. Thanks for having me.